Good day everyone, this is Group 4 and we are going to present on insulation administration, Brecht feeding, and total parenteral nutrition. And these are the objectives on this report.
Good day everyone, this is your first reporter, Stephanie Ann Cortez, and I'm going to report about the definition of terms and insulin administration. First, we have insulin. Insulin is a hormone secreted by the beta cells of the islets of Langerhans and lowers the blood glucose levels after meals by facilitating the uptake and utilization of glucose by muscle, fat, and liver cells. Number 2 is insulin administration. It is the action of administering insulin to a patient who lacks insulin hormones. For type 1 diabetes, it is given for life. For type 2 diabetes, it is given in a long-term basis to control glucose levels. Human insulins are produced by recombinant deoxyribonucleic acid. Next is injection rotation log. It is systemic rotation of injection sites. This is done to prevent localized changes in the fatty tissue or lipodystrophy. In addition, to promote consistency in insulin absorption, the patient should be encouraged to use all the available injection sites within one area rather than randomly rotating sites from area to area. The four main organs for injection sites, according to the speed of absorption, are the abdomen, the arm, the thigh, and the hip. Loading of syringe. This is the act of inserting a fluid in a medical device that is used to inject fluid or withdraw fluid from the body. Syringes must be matched with the insulin concentration. Currently, 3 sizes of unit 100 insulin syringes are available: 1 ml syringe, 0.5 ml syringe, 0.3 ml syringe. Small syringes allow patients who require small amounts of insulin to measure and draw up the amount of insulin accurately. The smaller syringes are marked in increments and may be easier for patients with visual defects and those taking very small doses of insulin. Next, we have lipodystrophy. This is the localized reaction in the form of either lipoatrophy or lipohypertrophy occurring at the site of injection. This is a genetic or acquired disorder in which the body is unable to produce or maintain a healthy fat tissue. So in these example pictures, the one on the left side is the lipoatrophy and the one on the right side is the lipohypertrophy. So the first type of lipodystrophy is lipoatrophy. This is the loss of subcutaneous fat. It appears as slight dimpling or more serious pitting of subcutaneous fat. And lastly, the next type of lipodystrophy is lipohypertrophy. This is the development of fiber fatty muscles at the injection site, which is caused by the repeated use of an injection site. If insulin is injected in discard sites, absorption may be delayed. This is an abnormal accumulation of fat underneath the surfaces of the skin. It is most commonly seen in people who receive multiple injections a day.
I'm Feby Camille Mundarte and I will be reporting on the anatomy and physiology of the pancreas. So the pancreas is located in the upper abdomen. It both has the exocrine and the endocrine functions. The exocrine functions include secretion of the pancreatic enzymes into the GI tract through the pancreatic duct, and the endocrine functions include secretion of insulin, glucagon and somatostatin directly into the bloodstream. Now, in the endocrine part of the pancreas, there is what we call the islets of Langerhans, which are collections of cells embedded in the pancreatic tissue. They are composed of the alpha, the beta, and the delta cells. The hormone produced by the beta cells is called insulin. The alpha cells secrete glucagon, and the delta cells secrete somatostatin. A major action of insulin is to lower blood glucose by permitting entry of the glucose into the cells of the liver, the muscle, and the other tissues. It also promotes the storage of fat in adipose tissue and the synthesis of proteins in various body tissues. Now, in the absence of insulin, the glucose cannot enter the cells, therefore it is secreted in urine. So the insulin is like your key so that the glucose can enter into the various tissues. The effect of glucagon is chiefly to raise the blood glucose by converting glycogen to glucose in the liver. Glucagon is secreted by the pancreas in response to a decrease in the level of blood glucose. The somatostatin is released by the delta cells in the pancreas, and it inhibits both the insulin and the glucagon. Now we're going to trace how these hormones affect blood glucose levels in the body. So when blood glucose level rises, the beta cells in the pancreas release insulin. Therefore, in response to insulin, the target cells take up glucose, and liver also takes up glucose and stores it as glycogen. Therefore, blood glucose levels fall and homeostasis is achieved, which means blood glucose levels return to normal. Now, if blood glucose level falls, the alpha cells in the pancreas release glucagon, and then the liver breaks down glycogen and releases glucose. Glucose is then released into the bloodstream to increase blood glucose levels. Therefore, blood glucose levels rise, and then homeostasis is also achieved, which means that blood glucose levels return to normal. Now, somatostatin is released by the delta cells from the pancreas. If blood glucose levels are low, somatostatin inhibits or stops the release of insulin. Therefore, blood glucose levels rises or increases. If the blood glucose levels are high, somatostatin inhibits the release of glucagon. Therefore, the blood glucose levels falls. The endocrine and the exocrine functions of the pancreas are interrelated, and the major exocrine function is to facilitate digestion through secretions of enzymes into proximal duodenum. And the pancreatic enzyme secretion is normally between 1,500 to 3,000 milliliters per day.
To continue, I am Lloyd Emmanuel Uliba, and I will be discussing to you all about objective number 3, which includes the indications, contraindications, complications, types of insulin and insulin syringes, and the factors affecting patients' response to insulin. So let us first discuss the indications. Insulin administration is indicated as a replacement therapy in the treatment of diabetes mellitus. Diabetes mellitus is a group of metabolic diseases characterized by elevated levels of glucose in the blood, also called hyperglycemia resulting from defects in insulin secretion, insulin action, or both. It has two types, type 1 and type 2. For type 1, this is characterized as destruction in the pancreatic beta cells. And for type 2, it is characterized by insulin resistance and impaired insulin secretion. Another indication for insulin administration is that it is a substitute for oral anti-diabetic therapy with maturity onset diabetes complicated by these conditions: ketoacidosis, diabetic coma, major surgery, infection, diabetes during pregnancy, and an impaired thyroid and other endocrine function. For ketoacidosis, this is due to the absence of or an inadequate amount of insulin, thereby causing decreased utilization of carbohydrate and increased breakdown of fat and protein, resulting to dehydration of carbohydrate and loss of sodium and potassium, chloride, and bicarbonate. For diabetic coma, this is when glucose levels surge very high, typically above 600 milligrams per deciliter. So it is also indicated for major surgery, for infection, for a pregnant diabetic mother, and for those who have impairments in their thyroid and other endocrine glands. Next, we will talk about the contraindications of insulin administration. So, first one is insulin allergy. So, when there is an insulin allergy, insulin administration is contraindicated. So, to know if you have insulin allergy, here are the symptoms: itching, redness, and burning at the site of injection. And another contraindication of administering insulin is the hyperinsulinism, which results from overproduction of insulin by the pancreatic islets. So its symptoms are hunger, nervousness, sweating, headache, faintness, and in severe cases, it also manifests seizures and episodes of unconsciousness. Now let us move on to the complications that result from insulin administration. So number 1 is hypoglycemia. People experience symptoms of hypoglycemia when blood glucose drops to 60 milligrams per 100 ml or less. The signs and symptoms of having hypoglycemia are the following: headache, altered consciousness, irritability, apprehension, weakness, tachycardia, lack of muscular coordination, diaphoresis or profuse sweating, and cold, clammy skin. Next complication is tissue damage. So this is manifested by insulin lipodystrophy, which as defined in the definition of terms as the localized disturbance of fat metabolism in the form of either lipoatrophy, which is the loss of subcutaneous fat, or lipohypertrophy, which is the development of fibrofatty masses at the injection site. Next complication is the erratic insulin action. So this means that the action of insulin have no regular or fixed course. The causes for this may be due to dietary factor, which includes irregular meals or omission of snacks, insulin technique errors, psychological errors, chronic overdose of insulin, intermittent use of hyper or hypoglycemic drugs, and or irregular exercise or rest periods. Insulin allergy, systemic allergic reactions, local allergic reactions, or somewhat related complications resulting from insulin administration. So these may be manifested by redness, swelling, tenderness, and coloration of the skin, and or generalized skin reactions. So the treatment for these reactions are desensitization with small doses of insulin given in gradually increasing amounts, associated also with generalized edema of anaphylaxis. Next complication is the insulin resistance. This term is applied to those patients who require require excess of 200 units of insulin per day to achieve normal glycemia. The treatment for insulin resistance as a complication of insulin administration is that the physician may first attempt to give the person port-based or human insulin. If port insulin or human insulin fails, the physician must order a high dosage of human insulin as needed to control an individual's diabetes. Next complication, or second to the last complication of insulin administration, is the insulin edema, which is a generalized retention of fluid. Is sometimes seen after diabetic control is suddenly established in a patient who has had prolonged uncontrolled diabetes. And last complication for insulin administration is the morning hyperglycemia. This is a phenomenon where there is elevated blood glucose level upon arising in the morning and may be caused by insufficient level of insulin and may be caused by dawn phenomenon, insulin waning, and Sumoigi effect. The dawn phenomenon, relatively normal blood glucose until 3 a.m. when the level begins to rise. The phenomenon is thought to result from nocturnal surges from growth hormone secretion that create a greater need for insulin. Next is the insulin waning. If an evening insulin dose or overnight basal pump rate is insufficient, blood glucose levels may creep up as you sleep. And the Sumoigi effect, nocturnal hypoglycemia followed by rebound hyperglycemia. So those are the complications for administering insulin. Next, we will talk about the types of insulin. First type of insulin based on time course is the rapid-acting insulin. The agents for this time course type of insulin is the Lispro, Humalog, Aspart, Novolog, and Glulicin Apidra. The onset for Lispro is 10 to 15 minutes, for Aspart 5 to 15 minutes, and for Glulicin is 5 to 15 minutes as well. The peak of Lispro is 1 hour, the peak for Aspart is 40 to 50 minutes, and the peak for Glulicin is 30 to 60 minutes. And the duration for both Lispro and Aspart is 2 to 4 hours, while the duration for Glulicin is 2 hours. This rapid-acting type of insulin is indicated and is used for rapid reduction of glucose level to treat postprandial hyperglycemia and or to prevent nocturnal hypoglycemia. The next type of insulin based on the time course is the short-acting type of insulin. So the agent for this is the regular insulin, brand names Humulin R, Novolin R, Elitin 2 regular. The onset for these agents or for this type of insulin is 30 to 60 minutes with 2 to 3 hours peak and a duration of 4 to 6 hours. Indication for this is that this is usually given 20 to 30 minutes before a meal, may be taken alone or in combination with longer acting insulin, which will be discussed later as we move on. Intermediate acting type of insulin is the next type based on time course. Its agent is the NPH or the nucleoprotamine hagidone with Humulin N, Elitin 2, Lente, Elitin 2, NPH, Novolin N, NPH. So for NPH or nucleoprotamine hagidone, its onset is 2 to 4 hours with a peak of 4 to 12 hours and a duration of 16 to 20 hours. For Humulin and etc., it has an onset of 3 to 4 hours with a peak of 4 to 12 hours and a duration of 16 to 20 hours. So these intermediate acting types of insulin are usually taken after food or after meals. The next type of insulin based on time course is the very long-acting insulin. So its agents are glargine, lantose, detamir, levemir, glargine 2-JO. So for glargine, their onset is 1 hour. The peak, it has no peak, so it is continuous. and its duration is 24 hours. For Levemir, its onset is 6 hours, still continuous or no peak, and then its duration is 24 to 36 hours. So very long-acting types of insulin are used for basal dose. And lastly, the last type of insulin is the rapid-acting inhaled insulin. So these are inhaled insulin that is indicated and used as rapid-acting insulin. So its onset is less than 15 minutes with less than or more or less 50 minutes peak and a duration of 2 to 3 hours. Next, we will talk about the types of insulin syringes. So there are 3 sizes of U100 capacity insulin syringes. They are the 1 ml syringe with a 100 unit capacity. Next one is 0.5 ml syringe with a 50 unit capacity. And lastly, the 0.3 ml syringe with a 30 unit capacity. By speaking of capacities, as you can see in the pictures, there is a 100 unit mark, or in the first picture, there's a 50 unit mark in the second picture and a 30 unit mark in the third picture, meaning that is their capacity of the syringe. So syringes must be matched with the insulin concentration. The concentration of insulin in the United States is U100, meaning there are 100 units per milliliter or cubic centimeter. Small syringes allow patients who require small amounts of insulin to measure and draw up the amount of insulin accurately. There is also a U500 or a 500 units per ml concentration syringe or insulin syringe available, but it is only by special order of patients who have severe insulin resistance and require massive doses of insulin. Last sub-objective for objective number 3 are to discuss the factors affecting patients' response to insulin. So these are the factors. Number 1, vascularity of injection site. Number 2, physical changes in the insulin. Number 3, concentration of the insulin. And number 4 is the route of administration. So the vascularity, meaning the condition or state of being vascularized or being supported and supplied by blood or blood vessels, affects the patient's response to insulin because it is where the insulin is received. Number 2, physical changes in the insulin may also cause an effect to the patient's response to insulin. The concentration of insulin as well is a factor that affects the patient's response, and the route of administration, since we all know that the abdomen is the fastest site of injection or administration for the speed of absorption of insulin. So the speed of absorption affects the patient's response to insulin.
I am Bianca Marie Ayordon, and I'll be discussing the guidelines of site selection and insulin injection rotation. First, insulin may be injected into the subcutaneous tissue of the upper arm and the interior and lateral aspects of the thigh, buttocks, and abdomen. Site selection should take into consideration the variable absorption between sites. The abdomen has the fastest rate of absorption, followed by the arms, thighs, and buttocks. Proper care of injection sites should be taken to prevent complications. Patients on insulin should be instructed to observe the following: to always visually inspect the injection sites before injecting insulin, to palpate the injection sites before injecting insulin, to avoid injecting into sites with lipohypertrophy, edema, inflammation, or signs of infection, to bathe with soap and water daily, to rotate sites of infection every day, not to reuse the needle if possible, Otherwise, limit the reuse when injections become more painful, but should not reuse needles more than 5 times. There is no need to swab the area if it's already clean. If the injection site is not clean, clean with plain water. Swabbing with spirit swabs is not recommended as it leaves the skin dry. Rotation of injection site is important to prevent lipohypertrophy or lipoatrophy. Rotating within one area is recommended. Areas of lipohypertrophy usually show slower absorption. The rate of absorption also differs between subcutaneous and intramuscular sites. The latter is faster and, although not recommended for routine use, can be given under other circumstances such as diabetic ketoacidosis or dehydration. The same site should be used for at least 1 month, and rotation should be done within the same site rather than rotating to 2 different sites with each injection. Each injection should be away from the previous one by a finger breadth or 2.5 centimeters. Use of the same site decreases variability in day-to-day absorption of insulin. A site with open wounds or blisters should be avoided. Blood glucose monitoring should be done on change of site. Change of site of injection is frequently associated with hypoglycemia.
Good day everyone, I'm Joshua Pandong and I'll be citing the different nursing responsibilities before, during, and after insulin administration. So before anything else, assess for contraindications or cautions, such as history of allergy, pregnancy, etc. Next is inspect skin areas that will be used for injection. Note any areas that are bruised, thickened, or scarred. Then obtain blood glucose levels as ordered to monitor response to insulin. Then, double-check the dosage drawn up for pediatric patients, for patients receiving concentrated insulin injection, or patients receiving very small doses, because even small errors in dosage can cause serious problems. During insulin administration, monitor patients receiving insulin IV carefully. Plastic IV infusion sets have been reported to remove 20 to 80% of the insulin, and dosage delivered to the patient will vary. Carefully monitor patients being switched from one type of insulin to another, as dosage adjustments are often needed. So after insulin administration, monitor patient response to therapy. Next, monitor for adverse effects such as hypoglycemia, ketoacidosis, and injection site irritation. Then, monitor patients' compliance to drug therapy, and the results of laboratory tests including urinalysis for evidence of leukosuria. Then monitor the patient's food intake and exercise and activities. Store the insulin in a cool place away from direct sunlight. Refrigeration is preferred, but do not freeze insulin. Then, keep life support equipment and glucose readily available to deal with ketoacidosis or hypoglycemic reactions.
Good day everyone, this is Chris Tokle from BSN 3D. At this juncture, we will be discussing on how to compute dosage of insulin and capillary blood sugar or CBS sliding scale. Preparing an injection using an insulin syringe. The physician or healthcare provider's order for insulin is written as units. The stock comes in 100 units per ml. Both syringes are calibrated or lined for 100 units per ml. Generally, doses less than 50 units are given with a low-dose insulin syringe. Here is one example. Order 60 units NPH subcutaneous every day. Supply, we have Humulin N and NPH human insulin. This is 100 units per ml. Now, we will be asking ourselves 3 questions. First, what is the order? Second, what is the supply? And third, which insulin syringe should I use? For this example, our order is NPH 60 units, and our supply is NPHU 100 per ml. So the insulin syringe that we will be using is 1 ml insulin syringe, since the order is 60 units. Now, using aseptic technique, draw up the amount required into the syringe. Another example, order 35 units regular insulin, subcutaneous stat. Supply, we have Humulin R, regular insulin human injection USP, 100 units per ml. Again, let's ask ourselves the three questions. For this example, what is the order? So, it is regular insulin 35 units. What is the supply? U 100 per ml regular insulin. What syringe should we use? Since the order is 35 units, we will be utilizing a low-dose insulin syringe. Afterwards, using a aseptic technique, drop the amount required into the syringe. Mixing two insulins in one syringe. Sometimes the physician or healthcare provider will order regular insulin to be mixed with another insulin and injected together at the same site. If this happens, remember 2 points. First, always draw up the regular insulin into the syringe first. Second, the total number of units in the syringe equals the two insulin orders added together. Regular insulin is often ordered with NPH insulin. Since regular insulin is clear and NPH insulin is cloudy, the mnemonic clear to cloudy may help you to remember which insulin to draw up first. To prepare two insulins with one syringe, first, inject into the NPH vial the amount of air equal to the amount of NPH insulin. Second, inject into the regular vial the amount of air equal to the amount of regular insulin. Third, withdraw the correct amount of regular insulin, the clear one. Fourth, withdraw the correct amount of NPH insulin or the cloudy one. And then fifth, the total amount of units will be the regular insulin amount plus the NPH insulin amount. Here is a visual presentation of how to mix two insulins in one syringe. Here is one example of mixing two insulins in one syringe. Order. First is regular Humulin insulin 15 units. Second, we have NPH Humulin insulin 10 units, everyday subcutaneously. Supply. First, we have regular Humulin insulin 100 units per ml. Second, NPH Humulin insulin 100 units per ml. The orders again are regular Humulin insulin 15 units and NPH insulin 10 units Humulin. The supply, regular Humulin insulin unit 100 per ml and NPH Humulin insulin unit 100 per ml. Since the total amount of both the insulin when added together is 25 units, we will be using a low-dose insulin syringe. Sliding scale regular insulin dosages. Sliding scale insulin orders refer to a method of insulin administration that is based on the blood glucose result. Sliding scale orders vary according to institutional policy. The blood glucose result often comes from a finger stick and uses some type of AccuCheck monitor. The order will read something like this. Blood glucose is abbreviated as BG. AccuCheck every 4 hours. For BG 251 to 300, call physician. For BG 201 to 250, give 5 units of regular insulin subcutaneous. For BG 151 to 200, give 3 units of regular insulin subcutaneous. For BG 101 to 150, give 2 units of regular insulin subcutaneous. For BG 81 to 100, give 0 units of regular insulin subcutaneous. For BG less than 80, give 1 ampule of D50 and call physician. In this example, he will test the blood glucose and according to the results, gives the ordered amount of insulin. Another type of formula is the calculation. So AccuChecks every 4 hours. For BG more than 150, give number of units of regular insulin based on blood glucose value minus 100, then divided by 40. In this formula, the denominator can change depending on the order and how controlled the patient's blood sugar needs to be. This formula also applies when you are giving continuous IV infusion of regular insulin. Here is one example. Order: sliding scale insulin. Blood glucose result 340. So in calculating this, we will change the BG into 340. So this will become 340 minus 100 divided by 40. So 340 minus 100 is 240, and then we will divide 240 with 40, and the result will be 6 units.
First is to define the terms in Brecht feeding. Number 1. Aspiration pneumonia. This occurs when regurgitated stomach contents or enteral feedings from an improperly positioned feeding tube are instilled into the pharynx or trachea, or when oral secretions are aspirated. A lung infection that develops when food, liquid, or vomit is inhaled into the lungs because the trachea and esophagus did not separate when the baby is maturing in the mother's womb. Number 2. Brecht feeder. It looks like a syringe that in place of a needle, it has a piece of tubing attached to its nipple end. Specialized bottles that does not require suction, including the special needs feeder, formerly known as Haberman bottle, pigeon, and the Mead-John cleft palate nursing. Special needs feeder and pigeon bottles are one-way flow valve in place. The liquid flows into the baby's mouth rather than the back of the bottle chamber when the nipple is compressed. The first type of feeder is the special needs feeder, formerly known as Haberman bottle. It has a long nipple chamber that can be compressed by the feeder for additional support. Next is the pigeon. It has a wide, bulbous nipple and wide cut tip which allows faster flow of fluid. Next is the Mead-John cleft palate nursing. It is a squeezable bottle with long, thin, X-cut nipple. This bottle allows the feeder to compress the bottle in coordination with an infant's suck, swallow, breathe pattern throughout the feeding.
Brecht feeding is a type of feeding used for cleft-lipped and cleft palate patients. There are modified or specialized feeding systems that are needed and available for this type of feeding, such as the special needs feeder, pigeon, and the Mead-Johnson cleft palate nurser. Cleft-lipped. It is a physical split or separation of the two sides of the upper lip and appears as a narrow opening or gap in the skin of the upper lip. The separation often extends beyond the base of the nose and includes the bones of the upper jaw and/or the upper gum.
To continue, I am Lloyd Emmanuel Oliva and I will be discussing to you the remaining terms to be defined. So the term we have here is cleft palate. A cleft palate is an opening or split in the roof of the mouth that occurs when the tissue doesn't fuse together during development in the womb or in the uterus during pregnancy. So a cleft palate often includes a split or a cleft in the upper lip or what we call cleft lip, but can occur without affecting the lip. So as you can see in the picture, the leftmost picture shows a normal palate. The middle picture presents to you a partial cleft palate, which does not include or go all the way through the border of the mouth or the teeth. And in the rightmost picture, that is a complete cleft palate. So again, it is an opening in the roof of the mouth with a midline fissure of the palate that results from failure of the two sides to fuse. The last term to be defined is choking. Choking is a blockage of the upper airway by food or other objects, which prevents a person from breathing effectively. Choking can cause a simple coughing fit, but complete blockage of the airway may lead to death. Choking is a true medical emergency that requires fast, appropriate action by anyone available. So, this is a partial or complete obstruction of the airway that can be due to a foreign body. As you can see in the picture, that is the universal sign of choking.
I am Bianca Marie Aradon and I'll be discussing the purpose of Brecht feeding. Brecht feeding facilitates feeding in newborns with difficulty in sucking. It prevents discomfort from swallowed air, prevents aspiration upon feeding, provides a safe and efficient feeding, and facilitates swallowing without regurgitation.
Hello again, I'm Joshua Pandong and I'll be discussing about the various nipples used. Formerly known as the Haberman, a slit in the tip of the nipple opens when a baby bites on it. Use the guides on the side of the nipple for slow, medium, and fast flow. Parents can also help the baby suck by squeezing on the nipple. A one-way valve prevents the buildup of negative pressure. This is a Mead Johnson bottle with a Nook nipple. A very simple and inexpensive setup is the MJ bottle with the crosscut Nook orthodontic nipple. There are no valves or extra pieces. The sides of the MJ bottle are very soft so that the parent can help the baby drink by squeezing the bottle. It takes a little practice to get the squeeze-swallow rhythm down. However, some babies can suck from the bottle without help. Next is the Mead Johnson bottle with the Ross syringe nipple. This nipple is very thin so the baby cannot suck on it. Parents must squeeze the bottle to help the baby eat. Some teams use this setup for post-op feeding. Could also be used for a baby who will not tolerate a nipple in its mouth. This is called the pigeon nipple and bottle. The pigeon nipple has a white cut tip and the plastic one-way valve which prevents negative pressure. One side of the nipple is softer than the other, so it works when the baby presses its tongue against it. Aim the notch in the nipple at the baby's nose for correct feeding. Another one is the soft sip feeder, usually used for post-op feeding. The valve prevents liquid from coming out unless the bottle is squeezed. The soft-sided bottle is easy to squeeze, and the valve can also be removed for feeding thin baby foods. May also be good for the baby who won't tolerate a nipple in its mouth. This is a Ventair bottle with a stage 2 nipple. Some babies are able to suck well enough to use the Ventair bottle with the Ventair stage 2 nipples. The nipples have a white cut tip.
Good day, this is Chris Kefeam Tokla again for the nursing responsibilities before, during, and after the procedure. Before, prepare all materials needed. Perform hand washing. Identify patient using two identificators, like the name and the birth date. Explain the procedure to the client or significant other. Create a pleasant environment and teach mother to manually express breast milk. During the procedure, support the baby in a semi-upright or sitting position with head and chest slightly tilted backwards. Auscultate the long sounds, check for choking and signs of aspiration as well as abdominal distension. Utilize a soft nipple. Follow the acronym ESSR when teaching the mother. E for enter the nipple into the infant's mouth. S for stimulate the infant to suck by stroking his or her cheeks. S is for let the infant suck. And R, rest the infant after he or she has sucked. Avoid hovering with the next spoonful of food as this may cause a patient to hurry and worsen any swallowing difficulties. Allow at least 5 to 10 seconds for each bite or sip. Carefully drip formula using a dropper or syringe into the newborn's mouth at a rate slow enough to allow the newborn to swallow. After, perform aftercare, let the infant burp, do hand washing, continuously monitor client for any signs of complications, report and document any instances of choking.
Hello everyone, my name is Stephanie Cortes, and I'm going to discuss about the definition of terms for total parenteral nutrition. Total parenteral nutrition is the method of providing nutrients to the body by an IV route. The method is used when a person cannot or should not receive feedings or fluids by mouth. This is also referred to as intravenous hyperalimentation. TPN is highly concentrated, hypertonic nutrient solution administered by way of an infusion pump through a large central vein. TPN combines dextrose and water, amino acids, vitamins, minerals, and trace elements and is given through a central IV line. TPN uses a solution of nutrients to meet the client's caloric and nutritional needs. If lipids are needed, they are given intermittently or mixed with a TPN solution. A total of 1 to 3 liters of solution is administered over a 24-hour period. The label of the solution is verified with the physician's order. The osmolality of the fluid and the concentrations of the specific components make controlled delivery essential. TPN is divided into two components, the major and the trace elements. The major components include carbohydrate, proteins, lipids, nitrogen, and electrolytes. The trace elements include zinc, iron, copper, manganese, cobalt, iodine, and chromium. Discuss total parenteral nutrition according to purpose. The goals of TPN are similar to the goals of enteral feedings. First is to improve the nutritional status, establish a positive nitrogen balance, maintain muscle mass, promote weight maintenance or gain, and enhance the healing process. TPN provides crucial calories, restores nitrogen balance, and replaces essential fluids, vitamins, electrolytes, minerals, and trace elements to meet the client's caloric and nutritional needs. TPN can also help promote tissue synthesis, wound healing, and normal metabolic function. TPN is used to help individuals who cannot get the nutrition through eating foods. It also allows bowel resting and healing while supplying adequate caloric intake and essential nutrients.
Indications and contraindications of total parenteral nutrition. Indications of TPN. First is impaired nutrient absorption, such as short bowel syndrome, enterocutaneous fistula, where distal access cannot be established, or small bowel obstruction. Second is required bowel rest, such as mesenteric ischemia, severe pancreatitis, or necrotizing enterocolitis. Next is disordered motility, such as prolonged paralytic ileus, but not gastric stasis, or pseudo-obstruction. The inability to achieve or maintain enteral access within 3 to 4 days. Someone with severe malnutrition, severe weight loss, and/or hypoproteinemia when enteral therapy is not possible. And lastly, markedly hypermetabolic patients with burns, sepsis, or trauma should be started on TPN immediately, even if they are well nourished. Contraindications of TPN. First is when patients who have functional and usable gastrointestinal tract capable of absorption of adequate nutrients. Next is when patient is taking oral diet. Next is when prognosis does not warrant aggressive nutrition support. Should not be used when malnutrition is used to rapidly progressive disease that is not amenable to curative or palliative therapy. It is not to sustain the hopelessly ill and may only prolong suffering. TPN should not be used when someone is hemodynamically unstable, when there is inability to obtain venous access, when the risks of TPN are judged to exceed the potential benefits, when treatment is anticipated for less than 5 days in patients without severe malnutrition.
To continue for objective number 2, I am Lloyd Emmanuel Oliva and I will be discussing to you all about the methods used in total parenteral nutrition. So, the methods used for total parenteral nutrition involves the two methods, the peripheral method and the central method. As you can see in the picture, there is TPN, or the peripheral parenteral nutrition, which is inserted at the peripherals, and the central method, which is inserted at the central circulation or central venous axis. So, peripheral method, TPN is administered through a peripheral vein. This is possible because the solution is less hypertonic than a full-calorie parenteral nutrition solution. TPN formulas also are not nutritionally complete because of their low dextrose content, and the length of therapy for this peripheral method is for 5 to 7 days. The next method is the central method. CPNs have 5 or 6 times the solute concentration of blood and are administered into the vascular system through a catheter inserted into a high-flow large blood vessel such as the superior vena cava. And this is administered via central circulation or the central venous axis. The next objective is to discuss about the types of catheter used in total parenteral nutrition. So first, we will discuss the types of catheter used for central method. So number 1 is the non-tunneled percutaneous central catheters. So these catheters are for short term only, less than 6 weeks. So the most common vessel used is the subclavian vein. This provides a stable insertion site to which the catheter can be anchored. It is easily compressible. It allows the patient freedom of movement and it provides easy access to the dressing site. Jugular vein should only be used as a last resort and only for 1 to 2 days. This type of catheters uses single lumen, double lumen, or triple lumen. So as you can see in the picture, that shows a non-tunneled central venous access device or catheter. So it is inserted in the subclavian vein, meaning under the collarbone or clavicular bone vein. The next type of catheter, still for central method, is the tunneled catheters. These are for long-term use and may remain in place for many years. Examples for these tunneled catheters are Hickman, Rochon, Rouviac, as you can see in the smaller picture. So these catheters are inserted surgically and are threaded under the skin to reduce risk of ascending infection to the subclavian vein and advanced into the superior vena cava. So these catheters are cuffed, as still you can see in the smaller picture. The cuff is near the exit site, which helps to anchor the catheter in place. So the bigger picture shows how the central line is inserted, tunneled, and where the line comes out. The next type of catheter used still for central method is the peripherally inserted central catheter or PICC or PIC. These catheters frequently are used for long-term IV access when the client will be managing IV therapy at home. Basilic or cephalic vein is accessed above the antecubital space and the catheter is threaded to the superior vena cava. So the PICC or PIC peripherally inserted central catheter is shown in the bigger picture, and the smaller picture shows the line of APICs or PIC. The last type of catheter used for central method is the implanted ports. So these are used for clients with chronic illness who require long-term IV therapy. Example for this type of catheter or ports are Port A cath and Mediport. So these are surgically inserted under the skin in the chest or the arm and appears as a bump under the skin as shown in the bigger picture. This type of device also is designed to provide repeated access to the central venous system, avoiding the trauma and complications of multiple venipunctures. Now let us discuss the types of catheter used for peripheral method. So first is the over-the-needle, or also known as angiocatheters, and are commonly used for adult clients. So this catheter or this plastic catheter fits over a needle or stylet used to pierce the skin and vein wall. Once inserted into the vein, the needle or stylet is withdrawn and discarded, leaving the catheter in place. So these pictures show what is a angiocatheter or over-the-needle catheter. And the last type of catheter used for peripheral method is the winged infusion set. So from the word wing, it appears looking like a butterfly which has a wing-like structure. So this second type of peripheral IV catheter is a steel needle variation, also often called butterfly due to its wing-like plastic tubes at the base of the needle. The flaps are held tightly together to hold the needle securely during insertion. After insertion, they are flattened against the skin and secured with tape. This type of catheter uses small gauge needles, and this is utilized or used for infants, blood draws, and for smaller veins.
I am Bianca Marie Aradonian. I'll be discussing the guidelines for TPN. First, we must consider parenteral nutrition for patients who do not have a functioning gastrointestinal tract or who have disorders requiring complete bowel rest. Second, we calculate requirements for water, such as 30 to 40 ml per kg per day, energy with 30 to 35 kcal per kg per day, depending on energy expenditure, up to 45 kcal per kg per day for critically ill patients. Amino acids with 1.0 to 2.0 grams per kg per day, depending on the degree of catabolism. Essential fatty acids, vitamins, and minerals. Third, we choose a solution based on patient age and organ function status. Different solutions are required for neonates and for patients who have compromised heart, kidney, or lung function. Fourth, use a central venous catheter with strict sterile technique for insertion and maintenance. Fifth, strict sterile technique must be used during insertion and maintenance of the TPN line. The TPN line should not be used for any other purpose. External tubing should be changed every 24 hours with the first bag of the day. Dressings should be kept sterile and are usually changed every 48 hours using strict sterile technique. Sixth, monitor the following laboratory test results to evaluate the nutritional status of the client receiving TPN and lipids, such as serum transferrin, serum osmolality, cholesterol, triglycerides, electrolytes, blood urea nitrogen or BUN, and urine creatinine. Seventh, monitor patients closely for complications such as those related to central venous access, abnormal glucose, electrolyte, mineral levels, hepatic or gallbladder effects, reactions to lipid emulsions, and volume overload or dehydration. Eighth, if TPN is given outside the hospital, patients must be taught to recognize symptoms of infection, and qualified home nursing must be arranged.
Today, I'm Joshua Pandong and I'll be discussing complications and its nursing interventions. Next up is glucose abnormalities, which can either be hyper or hypoglycemia and can occur in more than 90% of patients. Hyperglycemia can be avoided by monitoring plasma glucose often, adjusting the insulin dose in the TPN solution, and giving subcutaneous insulin as needed. Hypoglycemia can also be precipitated by suddenly stopping constant concentrated dextrose infusions. Liver dysfunction may be transient, as evidenced by increased transaminases, bilirubin, and alkaline phosphatase. It commonly occurs when TPN has started. Delayed or persistent elevations may result from excess amino acids. Pathogenesis is unknown, but cholestasis and inflammation may contribute. Progressive fibrosis occasionally develops, and reducing protein delivery may help. Painful hepatomegaly suggests fat accumulation. Therefore, carbohydrate delivery should be reduced. Hyperammonemia can develop in infants, causing them to become lethargic, twitching, and generalized seizures. Organon supplementation at 0.5 to 1.0 millimoles per kilogram per day can correct it. Abnormalities of serum electrolytes and minerals should be corrected by modifying subsequent infusions, or, if correction is urgently required, by beginning appropriate peripheral vein infusions. Volume overload may occur when patients have high daily energy requirements and thus require large fluid volumes. Adverse reactions to lipid emulsions may occur, such as dyspnea, cutaneous allergic reactions, nausea, headache, back pain, sweating, dizziness are uncommon, but may occur early, particularly if lipids are given at greater than 1 calories per kilogram per hour. Temporarily or permanently slowing or stopping lipid emulsions infusion may prevent or minimize these adverse reactions. And lastly, gallbladder complications, which can include cholelithiasis, gallbladder sludge, and cholecystitis. These complications can be caused or worsened by prolonged gallbladder stasis. Stimulating contraction by providing about 20 to 30% of calories as fat and stopping glucose infusion several hours a day is helpful. Oral or enteral intake also helps. Treatment with metronidazole, ursodeoxycholic acid, phenobarbital, or cholecystokinin also helps some patients with cholestasis.
This is Chris Kefayam Tokle for the nursing responsibilities before, during, and after the procedure. Before, review physician's orders and compare to MAR or the medication administration record and content label on TPN solution bag and for rate of infusion. Each component of the TPN solution must be verified with the physician's orders. Collect supplies, prepare TPN solution, and prime IV tubing with a filter as per agency protocol. TPN requires special IV tubing with a filter. Perform hand hygiene, identify yourself, and identify patients using 2 patient identifiers. Compare the MAR to the patient's wristband. Explain the procedure to the patient. Refrigerate solution until 30 minutes before using. Infusion sites are at high risk for the development of infection. During the procedure, use a strict aseptic technique with IV tubing, dressing changes, and TPN solution. If changing TPN solution, pause EID or electronic infusion device and remove old TPN administration set. Disinfect connections and change IV tubing as per agency protocol or policy. If starting TPN for the first time, flush and disinfect CVC lumens as per agency policy. Monitor vital signs, observing for signs of infection such as elevated temperature, since bacteria may grow in high glucose and high protein solutions. Monitor blood glucose levels, observe for signs of hyperglycemia or hypoglycemia, and administer insulin as directed. Since blood glucose levels may be affected if TPN is turned off, if the rate is reduced, or if excess levels of insulins are added to the solution. Monitor for signs of fluid overload. TPN is a hypertonic solution and can create intravascular shifting of extracellular fluid. Monitor renal status. Intake and output ratio, daily weight, and laboratory studies such as serum creatinine and BUN are used to assess renal function. Maintain accurate infusion rate with infusion pump. Mark rate changes gradually and never discontinue TPN abruptly. Abrupt discontinuation may cause hypoglycemia, and a sudden change in flow rate can cause fluctuations in blood glucose levels. After. Discard old supplies as per agency protocol and perform hand hygiene. Monitor for signs and symptoms of complications related to TPN. Complete daily assessments and monitoring of the patient on TPN as per agency policy. Note time when TPN is hung, number of bags and rate of infusion, assessment of CVC site, and verification of patency, status of dressing, vital signs and weight, client tolerance to TPN, client response to therapy, and understanding of instructions.